and AI is my special interest. Hope you can hear me at the back. Now, about multimodal predictive medicine, I think you have to understand that the radiologist's role, I think those who attended my lecture yesterday, you will realize that radiologist's role is completely transforming, changing. I met some of the students here at Yashoda, the radiology students, and they said they're not too sure about their future. And so I told them, I reassured them that radiology is going to be the only thing that's going to survive AI. All other specialties will be affected in some way or the other. Radiology will be the center of the hospital in the next 5 years. So you will be coming to the radiologist first, and who knows, the radiologist might be the managing director of the hospital because he's the guy who's holding the key to everything. So if anyone is having some two minds or sitting on the wall, whether I should discontinue radiology and whether I should go into banking, don't do that. Okay. So I think the previous speakers, sterling performance. I don't want to repeat anything. I'm always like that. I hate repeating stuff which already the previous speakers have spoken about. So I'm going to just tell you a few other things, simple things. I'm going to keep this very simple, very basic. You know, AI is too complex, especially we don't want to kill your brain with so much knowledge, you know, and it's not necessary. It's not necessary. Let me tell you, the engineers are there, they will take care of that. It's not your problem as medical students. Don't worry too much. The doctors are being intimidated by the engineers. They're having a crack at us. No. Take it easy. You do your job as a doctor. Your job is to look after patients, make diagnosis, treat the patient. Your job is not to study LLM or do coding, right? They get paid for that. Yeah, let's not do their job. So the 30-second thesis yesterday was just simple detection, reporting, and now it is orchestration. So the radiologist has moved beyond. So he's going to integrate multimodal data. What is multimodal data? I don't have to tell you. All of you are now probably experts, listening since 9 o'clock. And tomorrow is prediction. Prediction means you are predicting a disease before the patient falls sick. Even before the patient falls sick, you are predicting the disease. I can tell somebody that, oh, you might have cancer in 5 years from now. That's prediction. And that's exactly what AI is going to do in radiology. So the radiologists are going to write your fate well in advance. Let's keep it in layish terms. So you go to a radiologist, be nice to a radiologist, he will tell you what's going to happen to you in the next 5 years. Well, if you don't do anything funny like bungee jumping and other things, that's a separate problem that AI can't help. Nobody can help. Okay? So the field has crossed from research to workflow. And I'm sure you know what is workflow. Workflow is nothing but, you know, from the time the patient enters the hospital until the patient leaves. That's actually the workflow. How the patient is integrated into the system, how the patient registered, how does the patient see the doctor, what kind of treatment is started, and when is the patient discharged. And now AI is being integrated into each and every step of the way. That's called workflow integration. These words all sound bombastic. Don't bother. It's simple. So now, you see that the regulated tools are real. So there's a lot of regulation going on in India, in UK, in US. I would say that those of you who attended my talk yesterday, India is a lot more relaxed, chilled about validation. Of course, many of you may not agree. Please don't pounce on me. Compared to UK, MHRA is very, very hawkish. They don't allow you to do anything. They have a truckload of validated tools which we are unable to use because the MHRA says, no, it is not safe. So we are in a bit of a fix. I've been doing it for 5 years, and it's very frustrating when the regulators are too hawkish, very strict. They say, oh no, There are some governance issues here, some ethical issues, there are some confidentiality issues. Oh no, this tool is not safe. So there are issues. I'm not saying in India ICMR is too relaxed, but I know Dr. Mona Dougal personally, so I had a word with her, and she said, she's the director of ICMR, and she said, and she's also attending, I think she's giving a talk today, so I'd invited her. So she said, we are also becoming a bit tough on regulations. Workload pressure is real. The evidence is maturing, becoming more and more confident with what we have. And the next frontier, we have already started thinking about what next. As you have heard from my previous speakers, how to bring this into our daily lives. That is the next step. But still, mind you, there is a massive variation in the clinical practice. Most of the doctors are still probably 5% AI. 95% they are still illiterate about AI. So it takes time. So the core message is radiologists are not going anywhere. Now, all the steps, you see, which I mentioned, so the outcome is what matters. So what is foundation models? I hope you understand what is foundation models. So speech, text, reports, hearing, and all that is going to the brain. From there, it's processed, comes back through AI. So that's foundation models. And agentic AI is something which is independent. So it takes its own decisions. It does everything by itself without a human in the loop. And that is the future, agentic AIs. Okay. So there will be a point where, just like the driverless cars, things will be happening automatically. There won't be any human input. The patient comes, the AI will look at the patient, assess the patient, do all the bloods, the basics, do the ECG. We have it already in UK, so all the general practitioners, they have it. So all that the patient has to do is come in, there's a small cubicle there, they have to put their hand in, everything is measured automatically. The oxygen saturation, everything. So reporting is just the tip of the iceberg. So I think there's a lot of misconception that radiology reporting is the only thing which AI can do. I think radiology reporting is just one little thing, one little aspect. So there are so many other things, like the iceberg hidden under the water. Most of the things are actually beneath the water layer. So one has to understand that it's not the report alone. In UK, we're not worried at all about the report. We don't care. Why do you want AI to do your report? Your job is that, right? Why do you want a machine to write your report? And what's the job of a radiologist? AI should be used for workflow integration, for equipment, for radiation dose reductions, stuff like that. Not for writing a report. It makes no sense. We never use it for writing reports in UK. So the randomized evidence, so you can see that this is a big study we did on 8,000 patients, and this has been published. And we find that this is absolutely brilliant. It picks up breast cancer so early and so accurately. But a word of caution, human in the loop. It's not fully automated. Why this matters in India and similar health systems? There's an access problem. I think a lot of my colleagues, they agree. I checked with a lot of them yesterday. I think TB is a huge project which All India Institute is doing. One of my friends is involved in that, so I've been there last time. I've seen the project. It's amazing what they're doing. And they're rolling it out on a nationwide scale throughout India. And if this could be a game changer, we're going to pick up TB in every nook and corner of the country, which is not possible at the moment because we don't have access to the remote places. Now, these X-rays are reported by people sitting in the cities because some of the doctors, they don't want to go to the villages. So scans, the X-rays are done, and then they tele-reported. Everything is done with AI. So near-term predictive radiology. So these are the use cases. I'm sure most of you are working on these. So oncology, cardiovascular, emergency radiology like fractures, injuries, neuroimaging, brain. Yesterday I spoke about brain mapping, brain tumors, neurosurgery, and population screening. I think it's a very important statistics. If you are able, in India, if every person has an Aadhaar card, and I've been with the Minister of Health, I met him. I told him that this is a project. I came 2 years before. I met the minister in Delhi, and I told him, why don't you do this? He said it's difficult because Aadhaar card people have, but the ABA, that's a bit of a problem. And to marry the two, they're struggling, especially in the villages. It's not happening. And unless you do that, it's very difficult to keep a track on every patient, every citizen. But thankfully, Aadhaar card is very effective, and everyone has Aadhaar card. But when you tell people it's about health, I think it goes down the priority list of patients. When you tell them you won't get your salary, they will do it immediately. That's the problem. And I don't know how we are going to solve this. I also spoke to the Foreign Secretary. I also spoke to the Undersecretary. And they said, establish a team, and they're working on it. Let's see. I'm sure there are lots of people involved with government policies here. We have some very learned people in the audience. So my request to you is please do something about it. Try to marry the Aadhaar card with statistics. In the UK, we have a unique number called NHS number. Now, whether I'm in England, I'm in London, or if I go to Scotland, you know what? I can walk into any hospital. All I need is that number on my mobile. I give my number, they get the entire history within seconds. Throughout UK, Wales, Scotland, Northern Ireland, wherever I go, I have one unique number. And the same thing, if anyone does it in India, I'm sure a lot of people are already working on this project. So please do that. And that will be a game changer. Every citizen should be tracked. We should be able to track every citizen. AI will not be successful otherwise. These use cases and all these 10,000 cases, I took this, I took that. How do you know? How do you know what's the breast cancer rate in India? 1.4 billion population. How do you know? You might be just examining a small section of the population. So that's why the figures are not accurate. The credibility slide. So again, AI is having loads of issues, which I discussed yesterday. Data set shift, and then hallucinations, bias, equity failure, and regulatory screening. So not every program can be successful. There are so many validated ones which fall flat when you put it to real test. It doesn't help. So testing should be rigorous. Just like the COVID vaccine. You know that COVID vaccine was AI generated. How many of you knew that? Oh, good. Yeah, it was AI generated all over the world, including the Covaxin, Covishield, Pfizer, AstraZeneca. That's why they were able to come up with something in 6 months instead of 20 years. It usually takes 20 years. Yeah. But again, there were some issues which I don't want to talk here because that will cause panic. So this is something which AI can do, but you should know how to use AI properly. How to evaluate before adoption, so technical validity. I think a lot of you are here working on it, and even my previous speaker gave quite a lucid speech on that, and she gave loads of examples. That should be validated. And integrate, monitor, and scale. It's simple. It's very simple. So, who's a new radiologist? The new radiologist is one who can sense clinical disease, sense, not see. sits in the MDT meeting, is an excellent communicator. He has to interact with every doctor in the hospital. And there you see that. He's going to redesign everything, take care of the radiation, right from the time the patient enters radiology. Everything is controlled by him. Data steward, he can call himself a data steward. And then quality governance, ethics, patient privacy, these are key in UK. So I think we are bang in the middle as a radiologist for quality governance. Of course, the other specialists are doing in their own areas, but what radiologist does is he's going to oversee everything. So it's a future-proof skill. Radiology is not going to compete with AI. He's going to just get the assistance of AI. So get this out of your head that whether it's me or AI, no, nothing. AI is there to help you. When internet came, everyone said, oh my goodness, this is going to throw everyone out of job. What am I going to do? When mobile phones came, they said, finished, the world is going to end. Then what happened? We are totally addicted now. And we are a lot busier than before. So, whenever a new device comes, there will always be some initial fear, apprehension, resistance, and then slowly things settle down. And AI is experiencing that phase now. So this is implementation, practical implementation playbook for radiology departments. So you have to identify a pain point. I'm sure every department has a pain point. And then you validate it. If you're having some concerns, validate it. And if you're not sure about something, don't do that. Integrate, ensure that you do a complete risk assessment. And then let's say that what happens 2032. You see, we have what's called the drift dashboards. So I'm working on a project, huge project with King's College. It's a dashboard. Every radiology department will have a dashboard of the entire hospital where I can see how many patients are there in the surgical ward, how many patients are in the post-operative ward, how many are in the cardiothoracic, how many are in the urology, and how many are in accident emergency, how many are waiting, how many are in ICU, which patient is sick, which patient can go home, which patient is about to die, which patient had a cardiac arrest. Everything flashes on the dashboard. So that's what we should be aiming for, not to just, generate reports. I think that's like basics of Microsoft Word. That's not, AI is far more powerful, far more useful. So let's utilize AI properly. That's my strong message here today. Scale it. Scale it. Make it countrywide. Scalable. AI is scalable. So that's my strong message to all of you. So it's not an algorithm. It's not just a program, So it is a service, a predictive imaging service where you're helping the patient, you're working alongside the patient, you're talking to the patient. And yesterday, a lot of speakers, I was quite fascinated. A lot of speakers said, AI is going to free up your time for the patients, which is so good. We'll have more time for the patients. I see sometimes some of the busy hospitals, there are like 50 patients outside the door, and one consultant drowning in that crowd, no time even for a cup of tea. The guy is going to die of heart attack. Don't do that. Organize our lifestyles. We have appointments. Take appointments. Don't kill yourself. Why do doctors have short half-life or short lifespan? Because it's self-inflicted. Don't be too greedy for money. I'm sorry, youngsters, for you. Don't be too greedy. Money will come at the right time and the right way. Focus on patients. Be ambitious. Be skeptical. Be human. Chinnababu, he's a human. What I love in that guy, he is completely a different human being. I'm not sure how many of you know him. I know him very well, and thanks to Ishwar, Ishwar is the one who introduced me to Chinnababu. I'm like, I just love him. Be good humans. And that's the reference. I think I finished on time.